Okay, the major developments have been in the field of aortic stenosis, but also I think there's a very new concept for the first time put down the guideline, that's a heart valve center. The last guideline have introduced a heart team as a decision-making tool, but now the qualification of the center, I think that's a kind of paradigm change. The qualification of the center has to provide to treat valve patients at a very high level. Then, of course, the aortic stenosis, we have seen major developments over the last 5 years. Studies in aortic stenosis comparing TAVI or TAVR with conventional surgery in patients with low risk or with intermediate risk have been performed and have shown that TAVI is in many cases at least as good as surgery. So this had to enter the guidelines, and so the indication for TAVI has been widened. Use the indication for TAVI that we lowered the SDS score or the Euro score to the intermediate risk group of patients open now, and then we provided a table with a lot of factors that can favor TAVI or that can favor surgery. And that's a long list of parameters, and for one important parameter is, for example, also age. So you may consider TAVI now at the age of 75 if other factors speak against conventional surgery. In many countries, like in my country, we're performing already more TAVIs than surgical intervention in the aortic valve. But most important is, of course, that we have more studies and look now at the low-risk patient populations. And these studies, some of these studies are already underway to demonstrate that also in these patients, the TAVI is as good as surgery. And what on top, of course, we need is to show the durability of the valves we are using, and of course that takes time to prove that. But from my side, I'm very convinced that in 5 and 10 years, when the next terms of the guidelines will come out, probably for most patients with aortic stenosis, TAVI will be the treatment of choice.